Thank you. And to follow Rachael is just, that was such an inspiring talk, Rachael. Thank you so much. And like, your courage is really admirable as well. And I think it's really, really valuable for us as midwives and for healthcare professionals to really learn from women. And I guess for me today, I'm going to speak from my perspective as a researcher and as a midwife, but we really need to see women who have gone through the experience as the experts, particularly in this field. So thank you, Rachael, for that. So Sue gave me a lovely introduction. My name is Maeve OConnell and I'm currently working as a senior lecturer in midwifery at Cardiff. And I'm really delighted to be invited to speak tonight because this is an issue which is really close to my heart and something that I think that we can really make a difference as midwives and as healthcare professionals if we have the right information and knowledge going forward. So my PhD was on fear of childbirth and tocophobia, which is a severe fear of pregnancy and childbirth. And tonight I'm going to talk about a really, I suppose, simplified talk about preventing, recognising and responding to fear of childbirth and birth trauma. Okay, so we know that maternal mental health is a global health priority. The World Health Organization has recognised that in 2012, and the Lancet Perinatal Mental Health series highlighted perinatal mental health as a global health priority as well in 2014. So maternal mental health has really come to the fore only over the last really 10 to 12 years in terms of research. And we know that between 10% and 13% of women might have an undiagnosed mental health condition during the perinatal period. So there's been exponential interest in terms of research over the last 20 to 30 years. And historically, women have always had birth trauma, but in recent years with social media and the internet, women have really found their voice in terms of expressing this birth trauma and being able to share their stories. Pregnancy is a time of a massive life transition. It's a milestone and women really hope to have a positive birth experience. Women don't ask for much. All they ask for is an experience which leaves them psychologically and emotionally intact. But sadly, for some women, they experience birth trauma, and Rachael kindly shared her personal story, which really illustrated that for us this evening. But we know that when women experience compassionate, kind and respectful maternity care, they can actually develop their coping mechanisms and resilience. And when women have kind maternity care, a traumatic birth might actually be perceived as a positive birth experience. It's a very subjective thing. So in terms of the prevalence, Rachael already highlighted that approximately 4% of women have PTSD after birth. And globally, I suppose that this translates to 200,000 women in the EU and 157,000 women in the USA every year. So that's a significant proportion of women. And I just want to leave this here for a few minutes just to really absorb how women in the literature have described feeling. So as a midwife, how does this make you feel? Women have described feeling dehumanized. They felt powerless. They felt out of control. They felt numb and they felt violated. And one woman in a piece of qualitative research said that she felt like a piece of meat. And I think for me as a midwife and as a healthcare professional, we can almost feel defensive or think, well, to think that a woman would leave my care feeling like that, I think that's just horrendous. And we know from the literature that there's actually a discord between how healthcare professionals perceive their care and how women actually experience that care. And that's really important for us to acknowledge that this is actually how women can feel leaving our care. So how can we as midwives and healthcare professionals help mothers to thrive? Because of course, we know that mothers are surviving childbirth now. We've made great advances in terms of maternal morbidity and mortality, but we need to go beyond survival to actually helping mothers to thrive and to help mothers emerge from birth prepared, competent and confident and ready to take on the challenge of being a new mother. So to do that, we can look at three different aspects, which is preventing, recognising and responding to birth trauma. So in terms of prevention, it's really important to recognize that we have a really key role in actually transforming women's experiences of birth. So we have the power, and Rachael touched on that too. She really said, like, you know, in that quote from that one woman who said that she met one person who validated her experience, who listened to her and really made the difference. So we can make the difference as one person who meets a woman. Every encounter that we have is so important and can actually be the difference between a mother emerging confident, empowered, and with agency and in control of a situation, or feeling disempowered and emerging with birth trauma. So in terms of prevention, being aware of the risk factors in women is really, really important. So these are some of the risk factors which we can look at for women. So some of these, the key factors are a history of depression or fear of childbirth. It could be that they've had complications during their pregnancy. They may already have a history of post-traumatic stress disorder because, of course, there's a general history of PTSD in the population as well. They may have had obstetric or neonatal complications, or there might be prior lifetime experiences of trauma, things like childhood abuse, intimate partner violence. They might come from countries where there's war and conflict or torture. Low social support is a massive risk factor. And some of the strongest risk factors which we know are really important are previous negative birth experience, poor quality provider interactions, and I really want to focus on that aspect. Having an operative birth, lack of support during the birth, so being left alone or feeling isolated or feeling not listened to during the birth, and then dissociation. So these are really important to be aware of in terms of prevention of birth trauma. So looking at prevention in terms of a salutogenic kind of focus, looking at promoting resilience. So what is resilience? So we need to look at each individual's ability to bounce back in the face of adversity. So people have different capacity to thrive and to adapt in the face of adversity. But factors that we know are associated with this are optimism, having positive emotions about the birth, their social support, whether they're in a relationship, whether they have their family and friends around them, or whether they're completely isolated. Maybe they're vulnerable or migrant women who have language barriers. And then facing your fears and having a sense of purpose in life. So maybe in general, having a sense of purpose and wanting to be a mother. Maybe the pregnancy is planned or unplanned. It might make a difference in how you actually feel about yourself in becoming a mother and that transition to motherhood. There's other external factors then which can make a difference in terms of the birth environment or the environment around you. And then there's theories around genetics and epigenetics, which you need to be aware of. But we know that the majority of people are resilient, and in the face of adversity, a lot of women, a lot of people will face adversity and recover from it in time. And we know that support in labour and birth is critical to reduce risk and improve resilience. So the time that we spend with women is so important. I know myself, when I think of like that time in, let's just say, in a labour ward in an obstetric unit, when you're there in the room one-to-one with the woman and maybe her partner, maybe you're a student midwife, a midwife, it's very, very intense. And that time that you spend alone in that room, you really develop a relationship and you get to know each other. It's very, very special time. It's very sacred and it's very important. And it's only one time in that woman's life, you know, that you have that opportunity to make that relationship and to listen to them, you know, and to build that trust and that relational care. So that support during labour and birth is really, really important. And I think that actually women listen to every single word that you say, and they hang on to every diagnosis that you make. If you mention absolutely anything in that, you know, in that room, let's just say it's maybe you're in a labour room and the lights are down low and the woman is kneeling upright next to the bed, sucking on her entonox, really in strong, heavy labour, contracting. And maybe someone will come in, a doctor or someone will come into the room and turn on the lights and change the birth environment. And all of a sudden the labour changes. So that period of time in the labour, when, you know, it's such an intense period of time, and we really need to be mindful of the birth environment and of the woman and her partner. and making sure that we're maintaining a feeling of safety and a feeling of security for the woman, to make sure that she feels in control, that she has informed consent, that she is involved in the decision making, and that she's not powerless and kind of, you know, having things done to her. That's exactly what we do not want women to feel like, and unfortunately we know that that happens. So in terms of recognising birth trauma, so just to have a broad definition of perinatal post-traumatic stress disorder, PTSD, which occurs around childbirth, and it's usually postpartum in the context of traumatic birth, but it can actually happen at any time during the perinatal period. So just to be aware of that. And just to have an operational definition, this came from a concept analysis of PTSD. It's a subjective view of traumatic experience, which occurred any time before conception to 6 months postpartum, leading to specific negative symptoms and lasting longer than 1 month, which contributes to poor maternal and infant outcomes. So this is just useful in terms of, I suppose, midwives and doctors actually having an operational definition. So Rachael already touched on some of these symptoms, such as reliving the traumatic event, emotional numbing. Women can become very angry and irritable. It's a symptom of hyperarousal. They might avoid thoughts, places, or persons associated with the event. And they may have relationship problems and negative self-perception. And I might just tell a really quick story about the first woman that I encountered with PTSD. So I was working in the antenatal clinic in St. Thomas's, and I was waiting for a booking appointment. It was my last booking appointment, 12:30, and I was mad for my lunch. I was like, where is this woman? Where is she? So I rang down I rang her mobile, and her husband answered the phone. And I said, look, I'm up on the 10th floor. Is there a problem? Are you on the way? He said, yeah, we're down in reception. I'm really sorry. I just can't get her to get into the lift. She won't get into the lift. And I was like, what's going on here? So tore down the stairs, 10 floors in St. Thomas's. And I arrived down to the elevator, and I met them, and the woman was there, and she was Irish. So we instantly clicked. And I just said, what's going on here, kind of thing. And she said, I can't step into the lift. The last time I was in the lift, I had a postpartum hemorrhage. I collapsed, and I was on my way to the baby who's in the neonatal unit, and I just can't get into that lift. So I said, right, well, we've got to do your booking. So if you come with me, we'll go up the stairs. So I took her up the stairs. Went up 10 floors, and we had a good chat, and then I caseloaded her. So she was one of my women. So we built up that relationship. But she had that association with the hospital, first of all. You think even to get into the hospital, and then especially into the lift where she had collapsed. So that's just an example of a situation I experienced. Okay. So in terms of recognising birth trauma, it's really important to realise that it could take for up to 6 months after the trauma for symptoms to appear. So initially when a woman gives birth, she could be on this euphoria, elation, and positive high. You know, she might be just kind of, and as well as a bit of excitement around the baby and people are visiting and all of this distraction kind of going on. It can actually occur between 6 months and up to 1 year postpartum. So that's important to realise as well, depending on the situation. So we know that in recent years, mothers have shared and compared their birth stories on social media with connotations of not being believed, and they've used this hashtag #MeToo in the birth room. And I think that's really, really sad, because there's connotations there of not being believed. And I think that it's really important that social media has actually given women this voice, because our voice as healthcare professionals is actually very powerful, and we don't realise the power, especially I suppose as obstetricians and as midwives, that we have in validating women's experiences and acknowledging them to be true. And it's important to realise that a birth, which we might consider to be normal, could actually be perceived to be abnormal. So in terms of this example from Kissinger of a woman experiencing her waters being broken to speed up the labour, but she could have perceived it to be an undesired, unconsented medical intervention. So similarly, Beck recognised childbirth practices defined as normal by hospitals could be perceived to be traumatic if women felt powerless and out of control, and poor provider communication is really, really important. So I believe that we need to take a salutogenic approach, and the literature believes. And salutogenesis is a theory from Antonovsky in 1979, the 1980s, and he took a positive approach to health and well-being as opposed to pathologizing health. And by perceiving birth through a salutogenic lens, we're talking about birth as being a meaningful experience for women, which is spiritual, which is sacred. And I suppose it's really important for midwives to remember that every time you're in a birth, you're attending a birth, it's a sacred experience for that woman. It's a once or twice or maybe 3 times in a lifetime, few times in a lifetime event for some women. Well, it's very, very special. And we need to always remember that there is meaning in the event for that person, and it's a lifetime experience for them. So there's inconclusive evidence in terms of the best treatment for PTSD. Rachael spoke about EMDR and high intensity CBT, which would be the best available evidence. And in terms of the NICE guidelines, they don't recommend therapy that involves revisiting the experience, because usually this might not be helpful for women, especially in certain situations. But we do know that early identification of birth trauma and midwifery-led antenatal and postnatal interventions can help women. So if we don't treat PTSD, women can have depression, they might have all of these things, lack of breastfeeding, postpartum impaired bonding, secondary tocophobia, and really sad that some women might decide to have no further children. And, you know, that's really, really massive impact, I think, for women. So we need to acknowledge that there is a knowledge deficit for midwives and obstetricians in terms of preventing, recognising, responding to fear of childbirth, birth trauma and PTSD. And it is relatively new in terms of research, and there's still a lot we don't know about the etiology and the underpinning theories in terms of all of these things. But we must learn to listen to women, to reflect on and to learn from their experiences. And we have to aim to provide high quality maternity care, which is respectful, which is kind, compassionate, which is personalised, taking into account every person's individual needs, and which is woman-centred. We all need to commit to reducing birth trauma as healthcare professionals who work in maternity care, and we have to resolve to protect the emotional and psychological well-being of women and birthing people. We can do this by providing a known caregiver. Continuity of care is really, really helpful for these people. And we have to really do our best to make sure that there's access to specific interventions. And we ultimately have to have maternity care which is underpinned by dignity, respect and kindness. So I'd like to leave you with that thought. And I'd really like to thank you for your attention and for inviting me to speak tonight, and invite any questions.
Thanks for watching this video from the Maternity and Midwifery Forum. For more expert opinion and analysis, hit the button below to subscribe.